Good morning, everybody. My name is Tanvi Sukhtankar, and I am a postgraduate student at St. Xavier's College in Mumbai. I am currently pursuing my Master of Arts degree in psychology with majors in lifespan counseling. And I am also simultaneously part of the externship program that has been offered by RIT as part of their priority behavioral health and clinical psychology internship with St. Xavier's College. Today, as part of my poster presentation, I will be speaking about my project, which is validating and digitizing mental health screening measures for the Indian homeless population, which includes the GAD-7, PHQ-9, and the DSM cross-cutting. Before we begin, it's important that we understand what screening tools are. Screening tools tend to help us ascertain symptoms and diagnosis profile. They also help us determine the initial course of treatment, the severity of symptoms that the client may be showing, and also with respect to risk assessment. The PHQ-9, which is the Patient Health Questionnaire for Depression, and the GAD-7, which is the General Anxiety Disorder Screener, are both questionnaires that are used widely as part of screening tools for assessment and establishment of the diagnoses of depression and anxiety, respectively. The DSM cross-cutting is generally used to screen for pathology that is outlined in the DSM-5, and it does so by helping us assess 13 mental health domains that are paramount across various diagnoses that include but is not limited to mania, anger, sleep problems, anxiety, depression, and somatic symptoms. Coming to homelessness and mental health in India, it is important to know that in India, it is estimated that 1.8 million people are homeless, and mental health disorders are prevalent in this homeless population. In fact, research has also shown that 1/3 to 1/2 of this population is actually estimated to be diagnosed with serious mental health conditions. And in fact, during the pandemic, the COVID pandemic recently, considering the immense amount of pressure and the load on the already overburdened healthcare system and facilities in India, the mental health care needs of the homeless population were actually greatly marginalized and overlooked. Homelessness is a growing concern for India, and alongside that, the mental health of this population is also of great concern. Unfortunately, most screening tools and therapy approaches are developed in the West and hence are normed only in the English language. And due to immense linguistic diversity in India, not everybody is exposed to the English language or is fluent in the English language, especially the homeless population. There are versions of the PHQ-9 and the GAD-7 that have been developed in other Indian languages, such as Malayalam, Gujarati, and Telugu. However, these are languages that are specific to only certain states or certain regions in India. And the DSM cross-cutting, in fact, was also developed in Pakistan in Urdu. But again, Urdu is specific to certain regions in India only. As per the census of India that was conducted in 2011, 57.1% of the Indian population knew and spoke Hindi, of which 43.63% of this population actually declared it to be their native language or their mother tongue. And although the PHQ-9 and GAD-7 were already developed, like their Hindi versions were already developed by Pfizer, there is no Hindi version that is available for use for the DSM cross-cutting. And none of these tools have been validated on the Indian homeless population. Hence, the aim of this current research is developing a Hindi translation of the DSM cross-cutting and then establishing the psychometric properties of the GAD-7, the PHQ-9, and the DSM cross-cutting, so that these tools can be used with the homeless population in India effectively and Also making digital versions of the same available so that they can be used by other mental health professionals via telehealth as well. As part of this project to continue, mental health services were established at a homeless shelter in the outskirts of Mumbai in India. For this project, approximately 100 homeless individuals residing at the shelter and experiencing mental health concerns will be administered the screeners for diagnostic implications and treatment decisions. The psychometric properties of the Hindi versions of these screeners will then be computed, following which digital versions will be incorporated into the avatar assisted rich platform. Of 39 intakes, only 9 participants so far have been able to complete the measures due to language difficulties, cognitive problems, and the lack of knowledge of mental health terms. 62% of these participants responded to the English version, and 42% of these participants further reported moderate levels of depression on the PHQ-9, and 25% reported moderate, and then 25% further with severe levels of anxiety on the GAD-7, as compared to 50% of participants who reported mild levels of anxiety. This project aims at establishing norms for the Hindi versions of these screeners that can detect common mental health concerns. They will also help provide diagnostic clarity, especially for the homeless individuals who have difficulty in accessing services due to their lack of ability to communicate their symptoms. As India is a majorly Hindi speaking country, as mentioned ago, the norms and psychometric properties will help disseminate the screening tools to the general population. Digitization of these tools will assist in quick administration and screening, especially in settings that cater to a larger clientele. The homeless are most often ignored in the norming process of tools and therapies, and so this project will help in including them in the normative sample before gathering data from the general population. Before I conclude my presentation, I'd also like to thank Dr. James Meyer of RIT Global, Dean Wang of RIT CHST, the RIT Priority Behavioral Health team, Pastor Philip and Dr. Martin from Seal Ashram, and Dr. Rajendra Shinde, Dr. Ruby Pauri, Dr. Daniel Pereira, and Dr. Ruchi Brahmachari from St. Xavier's College, Mumbai, for giving me the opportunity to take part in this program and also in conducting this study. For any queries, please feel free to contact me on the email address. My email address has been provided in the bottom left corner of my poster. Thank you very much. I hope all of you have a great day. Good day. Bye-bye.